I just want to first check, am I audible? Can you see my screen?
Yes, Jacques, we can hear you and see your screen.
Excellent. Right. So welcome to this afternoon's deep dive collaboration between hematopathology, clinical hematology, and dermatology. And our topic is the blood, the brain, and the barrier, Sézary syndrome, a local perspective. Slide. But just before we start, some housekeeping notes. Recordings may be found at the Blood SA website, bloodsa.org.za. The resources deep dive. Please feel free, we will aim to unmute and ask the person. If you want to be on the mailing list, just send an email to Melanie at melanie.davids@uct.ac.za. CPD points is automatically submitted to the HPCSA, and at least 1 hour attendance is required to qualify for the CPD point. Questions can be sent to melanie.davids@uct.ac.za, and if you need a certificate. When the session is done and you're in your Zoom meeting, please complete the survey at the end of the session, and it's anonymous, so you can give honest feedback there. General information, please remember the upcoming 16th Annual Hematology Oncology Symposium, 13th to the 15th of September at Century City in Cape Town. This conference every year is really growing from strength to strength, and this year the topic is getting smarter in hematology. And also remember to submit your abstracts. There's a nice prize for the best abstract. You can get more info and links at bloodsa.org.za. So yeah, please register for HemOnc. Estelle, Hardin, Melanie, and Bridget for this amazing platform that we all know so well. So the agenda today is going to be started by Dr. Stephanie Kennedy from hematopathology, the blood, and then the brain is going to be Dr. Caroline Steyn, and then the barrier from clinical hematology, and then the barrier is Dr. Yashika Kalawan from dermatology. And I see next week our topic is going to be supportive care in hematology, CIA and ITP. So just as an introduction, our first speaker is Dr. Stephanie Kennedy. She recently passed FC PATH examination with distinction and will be a hematology registrar until the end of the year. She's been at the UFS for 13 years and holds the BMS, MBCHB and MSc internal medicine from the University of Edinburgh, all cum laude. And then Dr. Caroline Steyn is a specialist physician and clinical hematology at our unit, and she obtained a FCP and MEd in 2018 and certificate in clinical garden of internal medicine at UFS, and she's involved in student and registrar training, internal medicine and hematopathology. She's got a broad range of interest in the broad range of hematological disorder, both malignant and benign, and a special interest in patient blood management, and helps me a lot at the University PBM committee. And yeah, I think we form a very good team. And then lastly, Dr. Yashika Kalawan is a senior dermatology registrar at the University of the Free State. She completed undergraduate medical training at the University of KwaZulu-Natal, and has obtained a postgraduate diploma in dermatology from the University of Plymouth, and an advanced diploma in aesthetic medicine from the Foundation of Professional Development. So these are all our speakers, and I think they will entertain us well this afternoon. So with that, I'm going to end my share and allow, yeah, to sit back and enjoy the session. Please ask questions in the chat box.
Thank you, Jacques. I'm just going to quickly, I'm going to hand over to Dr. Kellerman. And just to say that we are going a little bit backwards today. We're going to go the barrier, the blood, and then the brain. So if you'll bear with us, we will, yeah, we'll start shortly. Thanks.
Good afternoon, everyone. I'm Yashika, and as you've heard, I'm one of the registrars here at UFS in dermatology. So I'm going to be presenting the barrier section. So our first case is of Mr. GB, a 40-year-old male from the Northern Cape who presented with a 4-month history of a scaly, itchy rash to Kimberley Hospital in April this year. He had no known comorbidities and on examination was noted to be erythrodermic with extensive exfoliation of scale, affecting more than 90% of body surface area. He also displayed palmar and plantar hyperkeratosis with associated nail involvement, as well as generalized lymphadenopathy. Mr. NR is our second case, a male, also hypertensive, also residing in the Northern Cape, who presented to Kimberley Hospital in October 2022 with a 6-month history of a skin rash as well as constitutional symptoms. On examination, he had generalized lymphadenopathy and was found to be erythrodermic. He was investigated further, however, was unfortunately lost to follow up. And then Mr. NR re-presented to Kimberley Hospital as per these clinical photographs shared last month. He was once again found to be erythrodermic with fissuring of bilateral palms and soles, as well as displayed generalized lymphadenopathy. Our third case, Mr. GM, a 21-year-old male from Tabanchu, was referred to our department in 2022 with a 1-year history of a dry, itchy skin rash. He had no past medical history of note, and on examination, he had generalized lymphadenopathy, erythroderma with scalp plaques exhibiting central regression features, and a papular follicular eruption noted on the trunk. His palms and soles displayed thick hyperkeratotic plaques, which were present bilaterally. All 3 of our patients were erythrodermic. So erythroderma is defined as a generalized redness and scaling of the skin, but it does not define a single entity as the clinical presentation compromises a variety of diseases. And in these 3 cases, the following differential was considered. Firstly, cutaneous T-cell lymphoma or mycosis fungoides, as well as Sézary syndrome. All of our patients presented with erythroderma, generalized lymphadenopathy, and had palmoplantar involvement. Dermatitis and psoriasis was also considered, but on history taking, we could not elicit any of these conditions previously. Pityriasis rubra pilaris was also considered, but on examination, no islands of sparing was observed, and only in 1 of our cases did we see a minimal perifollicular keratotic infiltrate. A stepwise approach can be undertaken in the management of these patients to ascertain the concluding diagnosis, as highlighted from our table in Bologna. But of utmost importance is a thorough history taking and examination. Ancillary investigations also aid in our diagnosis, so this can be skin biopsies, lymph node biopsies, as well as laboratory investigations such as flow cytometry in making our diagnosis of Sézary syndrome and mycosis fungoides. Histologically, skin biopsies are our main pillar in dermatology when diagnosing MF as well as Sézary syndrome. And what we can see by these photographs, if you look at the slide on your left, as highlighted by the red arrow, we see a dense dermal infiltrate of atypical lymphocytes. On your slide on your right, the red circles indicate our pathognomonic process of epidermotropism, where we see our atypical lymphocytes tracking up into our epidermis, and our yellow arrow indicating these atypical lymphocytes aggregating in clusters, what we term Fortier microabscess formation. Associated spongiosis and acanthosis can also be seen. Immunohistochemistry for CD4 and CD8 were also done, and in this case, being our third case, we saw a CD4 predominance. So in our third case, we visualized those very atypical scalp plaques and an 8 mm punch biopsy from the scalp as demonstrated by this video, displayed a perifollicular infiltrate of small to medium-sized lymphocytes and histiocytes with associated follicular destruction and granulomatous changes. No mucinosis was identified or large cell transformation noted. As well as from our third case with those hyperkeratotic plaques on the feet, a punch biopsy was done, which revealed epidermotropism with portray microabscess aggregation, confirming acral tissue involvement. So all of our cases displayed erythroderma, lymphadenopathy, with some exhibiting features of various clinical variants of mycosis fungoides. After punch biopsies, our patients were further investigated with blood tests, lymph node biopsies, as well as bone marrow biopsies, and a concluding diagnosis of Sézary syndrome was made in all three. So this brings me to our discussion, and I'd like to first discuss mycosis fungoides, which we know is the commonest type of non-Hodgkin's lymphoma, classically characterized by progression from patches to plaques to tumors. Patients usually present in their 4th to 6th decade of life, and an indolent course is usually seen. The etiopathogenesis has a multitude of theories, including infective causes, including viral, which was identified in our third case. Here are some photographs just displaying the classic features. So here we see our patch stage, moving on to our plaque stage, and finally tumoral disease. There are 3 WHO European Organization for Research and Treatment of Cancer clinical variants, the most common being folliculotropic mycosis fungoides, which usually presents as grouped itchy papules found in the head and neck region, often associated with alopecia due to the lymphomatous changes around the hair follicles, and may have associated mucinuria and nail involvement. The 2 other WHO clinical variants are granulomatous slack skin as well as pagetoid reticulosis. Mycosis fungoides Palmaris et plantaris is a rare subtype presenting with palm or sole involvement, and less than 30 cases have been previously reported. Palmoplantar involvement was noted in all 3 of our cases to a varying degree. So despite there only being 3 WHO variants, multiple other clinical variants have been documented as by Bahrami et al. And highlighted here, we see the 3 clinical variants which we noted in our cases. So moving on to Sézary syndrome, and this is defined historically by the triad of erythroderma, generalized lymphadenopathy, and the presence of neoplastic T cells or Sézary cells in the skin, lymph nodes, as well as the peripheral blood. Criteria recommended for the diagnosis of Sézary syndrome include demonstration of a T cell clone in the peripheral blood by molecular or cytogenetic methods, demonstration of immunophenotypical abnormalities, and an absolute Sézary cell count of at least 1,000 cells per microliter. In the WHO European Organization for the Research and Treatment of Cancer classification, demonstration of a T cell clone, preferably the same T cell clone in skin and peripheral blood, in combination with one of the mentioned cytomorphologic or immunophenotypical criteria, is suggested as a minimum criteria for the diagnosis of Sézary syndrome. So this is done to exclude patients with benign inflammatory conditions which may simulate Sézary syndrome, such as sometimes seborrheic dermatitis. So Sézary syndrome histologically is similar to mycosis fungoides, but sometimes epidermotropism is not present, and they may range from limited to superficial perivascular lymphocytic and eosinophilic dermatitis with or without spongiosis, sort of like an atopic-like picture, or to a lichenoid lymphocytic infiltrate. However, noted portray microabscesses are not commonly found. In this histological slide of a patient with Sézary syndrome, we see significant hyperkeratosis, acanthosis, but very minimum portray microabscess formation and very little epidermotropism appreciated. But what we can see is a nice dense dermal infiltrate of atypical lymphocytes. Treatment guidelines from Bologna direct management according to the clinical stage of the patient, but the main treatment pillars include skin-directed management, which can either be topical or procedural, and our second pillar encompassing systemic management. Systemic management is usually reserved for more advanced disease, and Dr. Stein's going to elaborate more on this. So all 3 of our cases were initiated on topical management of topical steroids, emollients, top preparations, as well as antibacterial washes, but no procedural therapy was commenced in any of our cases. Looking at the 5-year survival rate, patients with Sézary syndrome have a much lower rate of only 24% as opposed to our classic MF patients, documented to show up 88 to 100% 5-year survival rates. And just to note that in your clinical variant of follicular tropic MF, it drops to about 80% 5-year survival rate. So I'm going to hand over to Dr. Kennedy, and she's going to carry on with the blood.
Thank you, Yashika. So let's look at what we found in the blood of these 3 patients. So case 1, what you can see here is had a very high white cell count of 123. And on morphology, I enumerated his Sézary cells at 73%. So in my quick literature search, I found this to be a very, very high white cell count for Sézary. They have quite a variable range, but I must say this is probably one of the highest white cell counts that have been recorded. Here you can see some of his characteristic lymphocytes contributing to this lymphocytosis with the characteristic cerebriform nuclei. So what is a Sézary cell? The books describe them as being larger with a light basophilic cytoplasm, as you can see on the picture on the left-hand side, but there are also smaller variants. So small Sézary cells often referred to as Lutzner cells. Here you can just see some of these cerebriform lymphocytes in our first case, some more cerebriform lymphocytes, and even the smudge cells had a cerebriform appearance, and this might be quite a helpful feature if you have less abundant lymphocytes to say that these are cerebriform lymphocytes. So to better characterize these lymphocytes, we performed flow cytometry. His LST, which I'm not showing here, showed an expanded T cell population, and this was his TLPD. So the population of interest is the red population, which is positive for CD45, and it's CD3 positive. And there was a very expanded CD4 population, which you can see on the plot. So this CD4 positive population, the aberrant loss of T cell markers, so it was negative for CD2 and CD7, as well as CD26, and it was also negative for CD25. These Sézary cells, this abnormal T cell population was also positive for CD27, which is a memory T cell marker, which is often positive in Sézary syndrome. Also, it was negative for CD10 and CD30, which may aid in our differential diagnosis. So when we did this TLPD in the first tube, if you put certain markers, you can also enumerate the Sézary cells on flow cytometry, which I will show you a bit later exactly how. But for this specific patient, you can see that he had a CD4 to 8 ratio, which was very expanded of 27. He had CD4 positive, CD7 negative T cells, which were 89.99% of all the lymphocytes. CD4 positive, 26 negatives were 92% of all the lymphocytes. And in combination, these CD7, 26 negative, CD4 positive lymphocytes, which are like our surrogates on flow cytometry for Sézary cells, were 93% of all the lymphocytes. And using his FBC, we could calculate his total Sézary count at 79,570. And to make a diagnosis of a B2 criteria for Sézary syndrome, you only needed 1,000 cells per microliter. So he definitely met the flow criteria for Sézary syndrome. Then was case 2, Mr. NR. He presented, like many of our local patients with advanced lymphomas do, as a smear referred to the lab on a Saturday from Kuruman with no clinical information. So this patient had a lymphocytosis, as you can see there, the printout of his FBC, a white cell count of 75, a lymphocyte count of 39, and a monocyte count of 26. I will come back to those counts a bit later in this talk. Here you can see what I saw. Lots of cerebriform cells, small to medium in size. And here are pictures of some of the unique morphologies I noted in this patient on his peripheral blood smear. The top left, you can see a cerebriform nucleus, as well as at the bottom with a smudge cell. In the middle there is a very poor picture of a bilobed cell. So some Sézary cells can be bilobed like that. Just at the bottom of it are some cerebriform cells which almost have a monocytoid appearance. Hence the instrument which uses forward and side scatter on a Sysmex may be confusing these larger Sézary cells to be monocytes. On the top right there, you can see a very unique feature also in Sézary cells, this ring of vacuoles surrounding the nucleus. And at the bottom, there's even a flower-shaped nucleus. So here you can appreciate some more of these flower-shaped nuclei. So at this point, without any clinical information, adult T-cell leukemia lymphoma is definitely also on my differential. So usually when I see a patient with a lymphocytosis, my approach is very basic. Is it benign or neoplastic? And is it a small mature BLPD or TLPD? So usually if I don't see smudge cells, as in CLL, I go, oh snap, this is something else. So let's focus perhaps on the T-cell leukemic lymphomas for the purpose of this talk. So as you can see there, Sézary syndrome is definitely on our differential. Mycosis can have circulating cerebriform cells, but these are usually very scant, depending on the severity of the disease. TPLL can actually also have a cerebriform variant, but in TPLL, the white cell count is very high. Well, this patient has a very high white cell count, but they often have hepatosplenomegaly, which is not really a feature of our Sézary patients, which have lymphadenopathy. At the bottom, adult T-cell leukemia lymphoma have these characteristic flower-shaped nuclei, but they're also, depending on the type of adult T you have hepatosplenomegaly, hypercalcemia, positivity for HTLV1, and CD25 is characteristically positive. So just to note that some cases of Sézary syndrome can express CD25, but that's not the characteristic marker. And even a few cases have been shown to have HTLV1 virus infection, but clear etiologic role here has not been confirmed. And then on the other side are some very rare leukemic presentations, for example, angioimmunoblastic T-cell lymphoma, which has a follicular help cell phenotype. So if you have CD10 expression, you should think of that. And you can see that these cells actually also look quite convoluted in their nuclei and even have this ring of pearls that our Sézary cells had. So the histology of the lymph node is actually very important to distinguish this lymphoma, as well as the flow cytometry. And what we're going to emphasize throughout this talk is that Sézary syndrome is a clinical pathological correlation, and you cannot just look at the skin, the morphology, the flow, the lymph node biopsy. All of these need to fit together for the diagnosis. And then, as you all know, at the bottom there, peripheral T-cell lymphoma, NOS, is a DISPIN diagnosis. Just out of interest, this was a case report of an anaplastic large cell lymphoma with a small cell circulating lymphocytes, also quite convoluted. And interestingly, this case did not express CD30 on flow cytometry, but the lymph node biopsy on the right, you can see, was strongly positive for CD30 as well as ALK, which this lymphoma has. Again, emphasizing that you need to put all your pieces together. But on the smear, there was another clue to say that this might be a Sézary syndrome. So this is a picture of lymphocytes in this patient with this string of pearls, vacuoles surrounding the lymphocyte nucleus, also referred to as rosary beads. So then this patient, I contacted his doctor after I remembered the name. His surname sounded familiar, and I saw that he is a known Sézary who defaulted treatment 2 years ago. So I contacted his doctor and he was restarted on methotrexate therapy and then finally came to our clinic 3 months later. This was his peripheral smear on that day and his counts. What you can see here is he seemed to have responded to his methotrexate, a dose of 50 milligrams weekly. White cell count was now 34, it came down, and the morphology seemed to have changed. So some publications say that there is this heterogeneity in patients, especially when they are started on treatment, intra-patient heterogeneity. So in this case, the vacuolated lymphocytes came much more to the forefront. Here you can see some more of them, and even some more pictures of these lymphocytes. So what I did was actually, I destained one of the slides and did a PAS stain on it. So one of the older features that was described, one of the first features in Sézary cells, is their PAS positivity. So periodic acid Schiff, as you know, is it stains glycogen. So is this of any significance? So there's an old study from 1998, which says that it actually may be significant. So in this series, PAS positivity in the circulating lymphocytes was associated with worse prognosis. And in this case, the patient actually had a few features suggesting that he might not have a very good prognosis. And the rationale is here that the glycogen content being so high gives energy to the cells and may indicate a high proliferative index. Just to note that this is not something that is used today to determine prognosis, but I think something to keep in mind. So then we did a Sézary tube for him as well on flow cytometry. And in this case, you will notice the red population, it's sitting in the lymphocyte window, is CD4 positive, but it has lost CD3. And then also a large percentage of the CD4 positive cells lost CD7 and CD26. So this is not a classic Sézary phenotype. However, the criteria, if you read the subscript closely, any aberrant phenotype can be considered, and it doesn't have to be a CD3 positive population. In fact, many Sézary cells can have dim CD3 expression and rarely be CD3 negative. So in total, this patient had a Sézary cell count of 23,100. So I went back and looked at his old flow cytometry 2 years earlier at diagnosis. This was his TLPD, and at the time, the red population is his abnormal lymphocyte population. It was also CD3 negative, CD4 positive, 2 positive, and 5 positive, as well as 27 positive. Clearly a T cell population that had aberrant loss of CD3. It was also negative for CD7 and 26, as well as CD25. So I drew his bone marrow from the archives, and as you can see at initial presentation, his white cell count was 43. He had a lymphocytosis. His peripheral blood at the time already showed this characteristic vacuolation and cerebriform nuclei, as well as his bone marrow. So one can talk about the value of a bone marrow in Sézary syndrome. It's not really part of our staging. It's kind of part of the visceral involvement. But it's very difficult to see these Sézary cells, even in the peripheral blood, even more so in the bone marrow. But what I wanted to show you here is a picture of his bone marrow showing these vacuoles. So that might be a little bit of a clue in the bone marrow as to the involvement by Sézary cells, which was the case here. The third case is Mr. GM. His blood had a very different count and morphology to the first two cases. Although his white cell count was 29, you can see in the differential count there, the bulk of it is not actually the lymphocytes. He only had a lymphocyte count of 4, but he had a eosinophilia of 10 with 34% eosinophils. So he had a marked eosinophilia. This was persistent, and on the right-hand side, there's another printout about 2 months later where the eosinophil count remained very, very high. So his morphology, as you can see here, he has hypereosinophilia, and here or there, if you look carefully, you will find the cerebriform lymphocytes, some of them larger and some of them smaller, as shown in the picture. These pictures are from another slide of his about 2 months later, just to show the persistence of his hypereosinophilia, as well as the cerebriform nuclei of his lymphocytes. And also you can see the very reactive features of these eosinophils. Remember that we can't really distinguish clonal versus reactive eosinophils on morphology, and this degranulation can be seen in both. And in the case of a T-cell lymphoma such as Sézary syndrome, these eosinophils are not clonal, they are actually reactive, and we should all have a good approach to hypereosinophilia, which is a talk for another day. So this was his Sézary tube to try and enumerate and stage his disease. So what you can see here again, the population of interest is the red population, which was positive for CD3 and 4, and it had aberrant loss of CD26 and 27. In this case, the counts were not as obvious as in the first two. So his CD4 to 8 ratio was 11. His CD4 positive 7 negative T cells were 24, so that is less than 40%, and his CD4 positive 26 negative T cells were 7%, also less than the cutoff of 30% that is recommended. However, if you do a careful calculation of all his Sézary lymphocytes on flow cytometry, and you multiply it by your absolute lymphocyte count, you do get a total Sézary count of 2,400 cells per microliter, meeting the minimum criteria for Sézary syndrome of more than 1,000 cells per microliter. So for all three cases, we did a further workup, and this included PCR for T cell receptor gene rearrangement, both in blood and skin. They had skin biopsies with histology and immunohistochemistry, and same for their lymph nodes, as well as CTs for visceral involvement, bone marrows, and then important bloods. I just wanted to highlight here to confirm that these patients are negative for HTLV1, as well as LDH, which, if elevated, may indicate a poorer prognosis, amongst others. So how do we count Sézary cells and what are they? So Sézary syndrome was described by Dr. Sézary in 1939, and he called it erythroderma with cellular monstrua in the skin and blood. And he described this triad of generalized lymphadenopathy, erythroderma, and circulating cerebriform lymphocytes, which is still how we define Sézary syndrome today. Interestingly, about 10 years before, the same syndrome was described by a Russian, Arnoldzhevic syndrome, is what we would have called it if he had been recognized for his contribution back in the day. Then the ultrastructure of the Sézary cell was described in 1968 by Lutzner, and you will recognize this name, the Lutzner cells, the small lymphocytes, on electron microscopy. So in the olden days, if they were unsure, they would actually look at Sézary cells under the electron microscope, but this is very labor-intensive and specialized, so we no longer do that. But you can appreciate here why it was referred to as cerebriform lymphocytes. This image was taken by an electron microscope at Universitas Hospital back in the day when it was still actively used. I found this old image in the archives. So a word on what is a Sézary cell. So this picture just illustrates that Sézary cells, the cell of origin is considered to be a central memory T cell. And this is different from mycosis fungoides, which originates from a skin-resident memory T cell, and they have a distinct immunophenotype. So is it the same or not? It's a controversial topic, but the WHOIM5 say that they share overlapping clinical and pathologic features, but they are considered separate entities on the basis of difference in their clinical behavior and their cell of origin. So probably the most important thing here is that the skin-resident memory T cells, as well as the circulating memory T cells, both express CCR4, which is a skin-homing chemokine receptor, but Sézary cells actually express CCR7, which is the lymph node homing receptor, which allows these cells to migrate into the skin, but also out into the blood and to the lymph nodes, which is not really a feature of mycosis fungoides. And then in terms of the immune alterations in Sézary syndrome, the overall immunophenotype is shifted to a Th2 immunophenotype, which is also supported by the immune infiltrate and the cytokine profile. And then there's also molecular abnormalities, especially in JAK-STAT signaling pathways. So these patients, it's important to note, are profoundly immunosuppressed, and they are prone to secondary infections, which contributes to their mortality and also gives them a high occurrence of skin infections, especially. The etiology of Sézary syndrome. Recently, a publication described 2 mutational signatures, and this is also quoted in the new WHO. So the 2 mutational signatures are really cellular aging versus UV radiation. And then chronic antigenic stimulation, which we know leads to many lymphomas, seems to be an important factor in the etiology of Sézary syndrome. So Staph aureus comes to the forefront here, making us ask, is this a cause or an effect? So patients, as I mentioned, often have Staph aureus skin infections. And the question is this because of their immunosuppression and the compromised skin barrier? Or could it be a chronic stimulus that also drives the lymphoma? So a very recent paper showed that Staph aureus actually induces drug resistance in patients with Sézary syndrome. And the question is could it perhaps be a therapeutic target, and should we actually be taking nasal swabs for all our patients? So at the bottom, you can see how patients were treated both with chemotherapy and antibiotics, and that it actually improved their skin findings. Caroline will comment on this a little bit more later. So how do we stage them? Sézary syndrome and mycosis fungoides have the same staging system. It's not the same as our other nodal lymphomas. We don't use Lugano and Arbor staging here. We actually use the TNMB staging system. So T being the skin, N the nodes, M for metastases or visceral involvement, and then B for the blood. And if you have T4B2, you have Sézary syndrome. This TNMB staging evolved from 1979 when it was first described, and then it was revised in 2007. So our current definition of Sézary syndrome is T4B2. T4 criteria meaning you need to have more than 80% erythroderma, and you need to have 1,000 or more Sézary cells per microliter and a positive T cell clone, which must be the same as the peripheral blood, the same as the skin. And the reason for this T cell clonality is that patients with erythroderma, as we saw in our differential diagnosis, often have T cell clones circulating in their blood, because this is a finding that healthy individuals can have, especially older ones. Therefore, this clone that you detect in the blood must actually also be present in the skin to say that it is Sézary syndrome. The B-score is also important because it has independent prognostic value. What you can see here is patients with a very high B-score of more than 3,000 cells in number C here had the worst survival, and over 1,000, the survival is much worse than when it is below, hence this threshold. So how do we determine the Sézary cell count? So a very simplified way is on morphology, and it has been described to be more than 20% of the lymphocytes. However, a more exact way is to say you need to count the number of cerebriform lymphocytes per 100 lymphocytes, and this will be your Sézary cell count. And then you need to take this percentage and multiply it by your absolute lymphocyte count to get your Sézary cell count. And also you need to remember that 1 times 10 to the power of 9, you need to multiply by 1,000 to get your cells per microliter, because you need more than 1,000 cells per microliter, or more than 1 times 10 to the power of 9 per liter. Now, this pun is intended. I can do this if I concentrate extra hard with my lady brain. So morphology counting of Sézary cells in some of the publications you will see is notoriously subjective, with lots of inter and intra-observer variability. So our B criteria has evolved from this microscopic counting of brainy cells to, in 2024, flow cytometry to count our Sézary cells. And even that, as you will see from my talk further, is a bit of a daunting task. So in the future, will we not be using AIs to count these cerebriform cells for us? We will wait and see. So just quickly on the morphology in the past, they just said count the number of lymphocytes and the percentage of cerebriform forms. Are they less or more than 5%? That's all they reported in 1979. And this ISCL EORTC classification was updated in 2007 to say very specifically, and we still use this, you either have 1,000 Sézary cells per microliter, morphology was still accepted here, or on flow, or, and this was especially made a criteria in the presence of a low lymphocyte count. So for example, what if your lymphocyte count is only 1? How will you have more than 1,000? They accepted a CD4 to 8 ratio of more than 10, or an increase in CD4 cells with an atypical phenotype defined as more than 40% CD4 positive 7 negative lymphocytes, or more than 30% CD4 positive CD26 negative lymphocytes. And this is of all the lymphocytes. And I wanted to highlight this is not an and criteria, but an or. You only need one of them, as well as the positive T cell clone. And then in 2018, they came and they made it even simpler, saying we can stage our mycosis fungoides and Sézaries according to the number of Sézary cells, B0, B1, and B2. If it's less than 250, it's B0. If it's more than 250, it's B1. And if it's more than 1,000, it's B2. And then they went even further to say, and I like this sentence, or another aberrant lymphocyte population. However, the current WHO still accepts the Sézary count of more than 1,000, or the CD4 to 8 ratio of more than 10, or the increased aberrant populations with loss of CD7 or 26, and that is how we try and report it. So, easier said than done. What is the Sézary count on flow? So if you want to read a publication, this is a clinical cytometry guideline that was recently written in 2020. And it shows us here that there's two methods. So the first method on flow is to get your percentage of Sézary cells. These will be your CD4 positive 7 negatives, or CD4 positive 26 negatives. And actually in one publication, it clarified it for me, it is and or. And then you take this Sézary cell count and you multiply it by your absolute lymphocyte count, which you get on your FBC. And then you must remember that you are working in the right unit with cells per microliter, or 1 times 10 to the power of 9 per liter. However, what they mentioned in this publication is that this result, if you use the absolute lymphocyte count, can be falsely low if the hematology analyzer is not classifying neoplastic cells as a lymphocyte, and therefore not including them in the absolute lymphocyte count. So to circumvent this problem, they also suggest that you can calculate it first saying how many lymphocytes do you have on flow, what percentage is your total lymphocytes, and then multiplying this by your white cell count on the FBC. And what you can see clearly is our case 2, was a classic example. So I showed you earlier the Sysmex showed a monocyte count of 26. However, when I repeated the same sample on the Advia in our laboratory, because it was a bit suspicious to me, it became clear that the Sysmex was counting these caesary cells, the larger one, as monocytes because their forward and side scatter properties made them sit in the monocyte window. However, on the Advia analyzer, which uses peroxidase staining techniques, the monocyte count was only 1.5 and the lymphocyte count here was much higher. So if we calculated our total caesary count here on the two different analyzers, although in this case it doesn't really matter because it's way above 1,000, it's almost double if we use the Advia analyzer. Hence this recommendation by some to actually use the total white cell count. And it gets even more complicated than that. You can use this dual platform flow cytometry and full blood count testing, or you can just use labor-intensive bead counting on flow cytometry, or you can even do a dual assay on flow. So how do we count them? I'm going to show you step by step. If we just use this basic first tube, which includes CD3, 4, 7, 8, 26, and 45, and in our tube we also add an NK marker to distinguish them. It works as follows. Step 1, assign all the lymphocytes. Step 2, you make them T cells, and then you need to calculate your CD4 to CD8 ratio. So you assign your subsets for your T cells, CD4, CD8, double positive, double negative, and from this you will then get your CD4 to 8 ratio. As can be seen there in this patient, it was 27. Step 3, now you need to count your CD4 positive 7 negatives, which must be more than 40% of all the lymphocytes. So again, you have your CD4 positive cells here. Then you take your 7 negative CD4 positive population and you assign it as CD4 positive 7 negative, and then you can count them. And you have to write this down because you're going to change this just shortly after. But you can see here, it is 90% in this case, CD4 positive, 7 negatives. So you go back, step 3, make everything CD4 positive T cells again. Then you get your 26 negative CD4 positive cells and assign them and get a percentage, in this case, 92%. But now you need to get your total count. So can we just add these two populations together? As seen here, I've got CD7 against CD26. So here we have cells with loss of 26 at the top and loss of 7 at the bottom. So if we just put them over each other and add them together, you're going to see that this large double negative population at the bottom left corner is going to be double counted. So very simply, just draw a gate like this. So you have your total caesary count and you don't duplicate anything. And then if you take that count, assigning them something like caesary cells or double negatives, then you can use that percentage to ultimately calculate your total caesary count by multiplying that by your total lymphocyte count on your FBC. And that gives you a total caesary count of whatever. So that was fun. But these flow cytometry strategies, first of all, are not standardized. So not every center does them the same. And then also, there's a lot of arguments saying that CD4 positive 7 negative, CD4 positive 26 negative surrogates for caesary cells may not be sufficient on their own. However, in the meantime, we use these consensus recommendations to diagnose and also follow up. So here's some recommendations on when to repeat your flow, but in general, every 3 months. So the idea is actually to do it consistently the same technique, the same operator even, to get an accurate count each time. So, and this is where I got a little bit interested. There's inter and intra-patient heterogeneity in Sézary syndrome. And this study went and looked at a series of about 24 patients at their center and looked at the comparison between Euroflow techniques and conventional gating. And they found that there's actually quite a poor correlation between these two techniques, and that the heterogeneity is not even between patients, but also in the same patient. So for example, on the right, they had one case in their series who also had a CD3 negative population. And as treatment was started, this 3 negative population actually grew in this patient. So the question is it time to adopt a multicolor immunophenotyping approach to evaluate Sézary syndrome and mycosis? published in a series of papers in clinical cytometry in 2020. One of the papers here showed that determining immunophenotypic aberrancies has a better assessment than just counting 26 negative, 7 negative cells. And then in the same series of publications, this guideline was published. So what do they say here? They actually strongly recommend to quantify the tumor burden based on the Sézary mycosis fungoides cells identified on flow cytometry and not using just CD26 negative or CD7 negative, CD4 positive cells as surrogates. But what do we do in the meantime? They say, on the other hand, for the time being, in order to provide a comparison data to publish studies and for some consensus, we still report these percentages of 4 positive, 26 negative, 4 positive, 7 negative cells. Is there room for any additional markers? Now, this is a very interesting table of some other markers that we should consider putting in our tubes and their uses. So perhaps important ones to highlight here is PD-1, which is expressed in almost all cases, also a therapeutic target. CCR4, overexpressed in most cases. And then a very interesting antibody, KIR3DL2, which is a CD158K NK cell marker. And there's a study group from France by Professor Bourgault. They used this marker for the last like 10 years or so, showed it to be very sensitive and specific, and they use this in their center to follow up being an aberrant loss. So do these other markers actually have other significance, perhaps as therapeutic targets? So what we're saying is the classic immunophenotype of the Sézary cell is a CD3 positive, 4 positive, 8 negative T cell with aberrant loss of pan-T cell antigens, sometimes 2, 5, 7, and or 26. But it also expresses, as I've mentioned now, PD-1 in almost all cases, CD52, CD30, CD27, some cases have CD25, cutaneous lymphocyte antigen, CCR4, CCR7, and CD158K, the NK cell marker. So this is the marker I mentioned to you, which seems to be a very specific marker for Sézary cells. And it's also an antibody target. So one of the drugs that Caroline might mention to you is targeted against this antibody. What about other therapeutic targets? So CD30, brentuximab vedotin, CCR4, targeted by mogamulizumab, alemtuzumab, CD52, and PD-1 ligand inhibitors, pembrolizumab, nivolumab, are used in Sézary in cases that can afford this. So this will be my last slide. What is the local perspective on our cases? So how are they different from the literature or the European literature? Black patients seem to have a poorer prognosis. A younger age in our cases might be in their favor because worse prognosis is associated with an older age. But as you read in the literature, most cases of Sézary syndrome present in older patients of above 60, but we had quite young patients, so they are different. They have very high lymphocyte counts. They're all stage 4. They have very high B2 levels. The glycogen vacuoles is this associated with a high proliferation rate. They also had a high LDH, and they have limited therapies. And on this note, I will hand over to the brain in our team to discuss the management of Sézary syndrome.
Thanks, Stephanie. I think that gives new meaning to the word deep dive. That was a really nice deep dive into the diagnostic challenges in this disease. So thank you very much. The only reason that I'm the brain is because we had to complete the analogy. So this is just a section on treatment strategies and just the approach to the management of this challenging condition. Just anyone who was a kid in the 90s might remember Pinky and the Brain, who were this lab rat duo who wanted to take over the world every night. So just for fun. So just to recap, we've now already quite conclusively shown that the cutaneous T-cell lymphomas comprise a group of non-Hodgkin T-cell lymphomas primarily presenting with cutaneous involvement, but with the capability to involve nodal regions, blood and visceral organs, and MF being the most common type of cutaneous T-cell lymphoma, around 50% of all primary cutaneous lymphomas, whereas Sézary syndrome, although intriguing, is much rarer, although, all our patients actually had Sézary syndrome. So this is really a very interesting local perspective. So In the management of these patients, there are really some quite unique considerations and challenges. Firstly, these patients present with often a very high symptom burden. They have a highly heterogeneous presentation, and they require basically long-term, almost lifelong treatment. So unless they are very early stage and sort of have a watch and wait approach, these patients often require very consecutive and thorough follow-up with long-term strategies. There are no reliably curative therapies in the absence of highly aggressive treatment modalities, namely allogeneic stem cell transplant. Conventional treatments for this disease are not curative, and there's a really significant burden of impaired quality of life in these individuals. So the overarching tenets of therapy is really just the key concept being that one tries to maximize disease control, provide long-term palliation of symptoms, and avoid cumulative toxicity. This is a real concern. These patients, as I've said, because of the length and the duration of treatment that is required, it's very easy to accumulate therapeutic toxicity. So as a general approach, Stephanie showed this, the staging that we're familiar with now. Generally speaking, we have skin-directed therapies, we have phototherapy or radiation therapy, immunomodulation, which is I'll go into in a moment, as well as systemic therapy. So taking into account various patient disease and provider-specific factors, skin-directed therapies are usually used for patch plaque disease with limited skin involvement, in other words, stage 1A. I'll go into the individual agents as well. More extensive patch plaque disease is usually approached with phototherapy and radiation as either targeted therapy treatment or total skin electron beam therapy. And immunomodulatory agents like oral bexarotene, low-dose methotrexate, and interferon can also be considered at these time points. More advanced disease, including those patients with tumor stage MF or with extracutaneous disease, generally require systemic therapy. So this is a highly individualized approach, and the best option or the best therapeutic strategy is to really use a multidisciplinary team. It would not be in the patient's best interest for actually these patients to be treated with single providers. So this is just a nice overall strategy, kind of showing as the disease progresses, what are the options that are employed at different time points. So there really is, like I say, quite an armamentarium of agents available. Just actually want to go to this slide. I think it shows it a little bit better. So as this is sort of the cutaneous T-cell lymphoma treatment map, which is based on stage and responsiveness or refractoriness of disease. This depicts the recommended approach to the treatment and management of cutaneous T-cell lymphoma. So the interesting thing here is that the figure shapes correspond to the treatment applicability at each stage, with, as you can see on the legend at the bottom, that large areas signify higher expected response rates. So starting off with topical therapies such as topical corticosteroids and bexarotene gel, as well as the application of nitrogen mustard and then ultraviolet therapy. And then photopheresis comes in as patients reach erythrodermic stages. And then with the application of electron beam therapy and oral bexarotene forming sort of more of a later therapeutic approach. And this very, very interesting agent called stenoleukin diftitox, which is a interleukin-2 agent combined with a diphtherotoxin, which is very interesting, and then chemotherapy forming sort of important strategies later on. So just in terms of prognosis, we've already spoken about this very quickly, but I'll just show, this is from the aortic guideline, showing the quite significant drop-off in 5-year disease free survival as a stage increases. So where patients with stage 1A disease have an almost 100% 5-year disease-free survival, this really decreases significantly as stages become more advanced with less than 20% stage 4B. Then therapy, as we've said, it usually is a stepwise palliative approach. Patients with advanced stage disease, many tumors, and significant blood or nodal burden are associated with a higher risk of progression. And these are some of the independent risk factors that Stephanie also alluded to regarding adverse prognosis. So patients with extracutaneous disease, advancing age, the presence of large cell transformation, and a high LDH are all associated with an adverse prognostic outcome. Then, interestingly, these are also seen as pertinent to prognosis. So the patients with follicular tropic variants, so our patient, Mr. G. M, was shown to have a follicular tropic variant of Sézary, or of MF rather. This involves really the infiltration of skin follicles by neoplastic cells, and patients with thick plaques and tumors also have a worse prognosis. The patients with large cell transformation occurs in about 10 to 25% of patients with mycosis fungoides. Also high incidence when stage is advanced, and essentially any new papules, nodules, or tumors require biopsy to exclude large cell transformation. Age we've spoken about, and then interestingly, this issue about disease biomarkers is certainly a topic that I think is intriguing. Not sure how applicable it is in our setting, but really no biomarkers have been validated for prognostic value in mycosis fungoides and Sézary syndrome. The immunophenotypic and molecular biomarkers that Stephanie spoke about that are used to distinguish mycosis fungoides from other cutaneous T-cell lymphomas haven't really been tested for independent prognostic value. But RNA sequencing from skin lesions there was a study of 110 patients where they biopsied skin lesions and RNA sequenced these lesions, showed that expression of certain genes were associated with disease progression. These were TOX, FYB, and CD52. Essentially, these genes encode proteins implicated in T-cell development, activation, and migration. Among patients with early stage disease, expression of CCR4 was also a predictor of disease progression. And then there was a Danish study that looked at the presence of microRNAs in diagnostic biopsies from about 150 patients, found that there were certain microRNA signatures that also, interestingly, were stronger predictors than current clinical factors, but these are very early and still also require validation. Then there are some prognostic indices. The one is the CLIPI, which was developed by analyzing 1,502 patients with MF Sézary in the UK. They looked at various prognostic factors that defined 3 specific prognostic groups, and these factors were male gender, age above 60, the presence of plaques, the presence of follicular tropic disease, and then N1 or NX nodal disease. Early stage patients had a relatively good 5-year overall survival, up to 97%. And again, this dropped off significantly as advanced stage was patients with advanced stage disease, where the overall survival was only about, in the range of 40 to 60%. And then this International Cutaneous Lymphoma Consortium conducted this ProCLIPI study, which also looked at a large group of patients at various international centers with advanced stage disease, and they found that the independent prognostic factors in their study were, again, at stage 4. Age is clearly a recurrent theme, as well as an elevated LDH and large cell transformation. So in terms of therapeutic options, we have early stage options. A watch and wait strategy or an expectant policy remains a legitimate management option in patients with stage 1A disease. These patients actually have as we saw before, a very low risk of progression and actually a life expectancy similar to that of the general population. Patients need to be carefully monitored because some of the patients will eventually progress. And patients presenting with plaque disease, in other words, T1, 2B, seem to be at higher risk. And so a watch and wait strategy should essentially be offered mainly to patients with T1A disease that are well informed and know, to follow up if there's any sign of progression. Then we have skin-directed therapies. These encompass steroids, chlormethine. Then there are some topical agents without clear recommendations, which I'll allude to now, and then the phototherapy and electron beam therapy. So let's talk about skin-directed therapy. So again, I was sort of straying into a realm that's not natural to me as a hematologist, talking about topical therapies, but I must say I've learned a lot preparing this talk. So the dermatologists in the audience are very welcome to comment as well at the end. But this is essentially recommended as a first line in early stages of mycosis fungoides, and also used throughout all stages in combination with systemic options and even in advanced disease. So the two sort of cornerstones here are topical corticosteroids. Although widely used, it's interesting to me that the evidence is not very robust for the application of topical corticosteroids. However, this remains a commonly employed strategy in clinical practice. There are a number of different types of topical corticosteroids, varying from sort of low potency to intermediate to high potency and super high potency, which these are the preferred agents, as they apparently reduce the risk of skin atrophy. And one of the options there is this clobetasol propionate, shown in the picture below the Hulk. And the efficacy of these agents actually are in practice, there's an overall response rate of up to 94%. So clearly beneficial in many patients. And then there's this interesting other agent, which is topical metchlormethamine or chlormethine gel or ointment. And this has actually been used, it's an alkylator, it's a nitrogen mustard compound. The way it works, obviously, is as alkylators do, they induce double-stranded DNA breaks and cause apoptosis in these skin-homing malignant T cells. And they also suppress expression of DNA repair in malignant T cells in the skin. And this was just an interesting study by an American group published in the American Journal of Clinical Dermatology, the PROVE study, where essentially they really just looked at real-world experience or data with chlormethine gel as opposed to other therapies. So the combination of chlormethine gel with topical steroids and other treatment, or patient just receiving chlormethine gel without topical corticosteroids. It was found, the point of the study was really just to kind of, like I say, get a real world experience with the agent. And it was found really that it was a generally well-tolerated agent with median time to skin clearance of 6 to 8 months, but the sort of peak time of treatment was actually at 18 months. So it appears that this is a topical option that needs to be used for quite some time to really get maximum response. This is just an interesting phenomenon, is that the erythema and skin involvement can actually transiently worsen when applying this product. And it appears that this is actually maybe an indicator of clinical response. So patients get sort of a contact dermatitis when using chlormethine gel that seems to get worse at about a month of therapy. And then as time goes by, this resolves. Yeah, there's this sort of clinical response at 1 month is really quite modest, usually probably because of this contact dermatitis that is present. And then there's a steady increase to peak response as time goes by. Then just touching on some other topical therapy, this encompasses topical retinoids, topical calcineurin inhibitors, and then some others. So topical retinoids, pertinently, the one that's got the most evidence is bexarotene gel. This was approved by the US FDA for cutaneous T-cell lymphoma early stage, or this is approved rather, usually used in patients with refractory disease or those that are intolerant to other therapies. And interestingly, the Europeans haven't approved this. So it's approved in the US, but not in Europe. I can be corrected if anyone has any other information. Then in terms of topical calcineurin inhibitors, the rationale for this is that the calcineurin pathway is often activated in mycosis fungoides. This encompasses tacrolimus and pimecrolimus. These agents were actually originally developed for atopic dermatitis, and there was a study called the PIMTO-MF study, which was a multi-center phase 2 trial of a smallish number of patients. But more than half of these patients had overall responses with pimecrolimus. Most of them had partial responses, but there were responses seen and fairly well tolerated agents, with major side effects being transient burning or pruritus. Several large cohorts have actually shown no strong evidence between the use of topical CNIs and developing lymphoma. This is sort of seems to be a concern when using these agents, and this is per the European Oncology Group recommendation. So just other topicals. When I read imiquimod, I immediately thought back to medical school when this was kind of the only reference I have for this is in like warts, yeah, genital warts, and I think also in basal cell carcinoma, if I'm not mistaken. So I was interested to see that this has also got some evidence for use in cutaneous T-cell lymphomas. So this is a toll-like receptor agonist and has been used for MF in case reports. Then some other interesting, so there's another agent called, well, it doesn't even have a name yet, it appears, anti-CD47 therapies. It's got just a kind of a trial number assignment, TTI-621. There's a fusion protein that blocks the interaction actually between malignant lymphocytes and macrophages, which is interesting. This appears to be more efficacious when used with intralesional administration. And then there are some other agents like topical methotrexate plus lorazepam, which enhances the penetration of this agent into the skin, and 5-fluorouracil. But I'm not sure. I don't think these are commonly employed in clinical practice. Then another sort of major component of treatment here is radiotherapy and phototherapy. So UV phototherapy has been used for many years in the treatment of mycosis fungoides. So PUVA is the combination of psoralen and UVA, and then narrowband UVB is also seems to be, like I say, a cornerstone of management with these patients. They can still induce quite high response rates per literature. Interestingly, it seems that broadband UVB has disappeared from dermatology offices in most cases. It appears that that broadband UVB has more erythroderma or more sunburn really when used for this indication, whereas narrowband has the same therapeutic effect and with less side effects. And then there's this interesting this interesting concept of in-bath PUVA8 methoxypsoralen. So the patient is actually immersed in a bathtub of medicated water, but because the head is not included, this is a concern because this may be a site of skin relapse. And then there's also this entity called excimer laser, which is a form of UV light that allows shorter therapy duration, focuses on discrete skin lesions, and allows lower UV exposure, but I've been told on good authority that that's certainly not available in our setting. Then in terms of photodynamic therapy, this is another form of sort of light therapy. So this is where a photosensitizer, which is a drug that is given to the patient, is applied to the target organ, and then this drug is activated by light of the appropriate wavelength and intensity. And this results in the formation of cytotoxic oxygen-free radicals only in that area, so hence causing cell death in the exposed or those specific treatment areas. The most well-known photosensitizer is 5-aminolevulinic acid, ALA. This has mainly got an application in skin cancer, but it seems that novel therapies or newer photosensitizers and novel prepping methods are being developed to improve the use in cutaneous T-cell lymphoma. And there's a trial that was looking at this agent called hypericin, which induces much better responses, up to 50% after 3 cycles. Hypericin is an agent that inhibits actually malignant T-cell proliferation and causes apoptosis. It's not yet also FDA approved, but may represent an additional consideration as time goes by. Then, in terms of what is available locally, locally in the Free State or in the public sector, we do have or there is space to do electron beam therapy, conventional total skin electron beam therapy. But unfortunately, due to sort of just the space on the actual machine, there's really only about one patient that can be treated at a time. So it seems that this is not obviously available to most patients, but in a patient where this is indicated, there is this option locally. So this either is this refers to total skin electron beam therapy. Unfortunately, because of the chronicity of the disease, which we've spoken about, and relapses, skin toxicity prohibits repeated courses of radiation. So this really seems to be sort of a once-off attempt. But lower doses of electron beam therapy has largely replaced traditional doses. So these 10 to 12 gray therapeutic doses are being employed more, more than the higher doses, which is certainly intuitive. These lower doses provide rapid and reliable reduction in disease burden, and in this instance can be given in multiple sessions because the therapeutic or the toxicity is less than high dose. Right, then we obviously need to speak about systemic therapy, and I'm aware that our time is not, we don't have a lot of time left, but I'm going to touch on these because this is really interesting. So systemic retinoids include all trans-retinoic acid, which we as hematologists are very familiar with, isotretinoin, acitretin, and bexarotene. Interestingly, bexarotene is actually called a rexinoid, not a retinoid, because this is a substrate of the retinoid X receptor, which is the only retinoid that is specifically been designed or developed for and approved for cutaneous T-cell lymphoma. I know that locally as well, our dermatologists use acitretin, and I'm not sure about Atravils. We'll speak to them in a moment. These patients, or the use of oral or systemic retinoids induce better responses when used in combination with chemotherapy or photochemotherapy. These agents only induce moderate responses when used in isolation. And it appears that there is no real superiority of one over another, according to published evidence. So these agents are generally well tolerated. There are some common class-specific adverse effects like teratogenicity, dry skin and mucous membranes, and hyperlipidemia. And bexarotene specifically is known to cause central hypothyroidism. So that's something to watch out for when these patients are on this agent. Interferon, so only pegylated interferon alpha 2A, Pegasus, is still available after the withdrawal of recombinant interferon. This open label multi-center dose escalation study evaluated the safety and tolerability and efficacy of pegylated interferon in patients with cutaneous T-cell lymphoma. And this was administered subcutaneously at 180, 270, or 360 micrograms once weekly for 12 weeks. These patients were assessed for efficacy at this time point, and what the outcome was the proportion of patients with CR or partial response. So this agent appears to be well tolerated, showing good response rates. These patients this agent may be an option for patients not tolerating standard interferon preparations. However, it appears that still, larger clinical trials are needed. But this is definitely an option for patients with recalcitrant disease. In terms of cytotoxic chemotherapy, agents can be effective against MF, especially for multiply relapse disease or aggressive disease. So the interesting thing here is that single agents are preferred over combination chemotherapy because of the fact that multi-agent regimens induce only short-lived responses and have increased toxicity. The place where this would be important is if a patient is being offered for allogeneic stem cell transplant, then it would be preferable to get the patient into a CR prior to transplant. So this would be where combination therapy would be used. Otherwise, single agents are preferred. So just touching on these agents, in terms of gemcitabine, these patients using gemcitabine have a frontline overall response rates of up to 75%, with about a fifth of patients achieving a CR. Gemcitabine as a single agent is relatively well tolerated with only mild hematological toxicity. Liposomal doxo, there have been multiple studies looking at doxorubicin, mainly in advanced MF. These patients also appear to achieve about a 40% overall response rate, with a third of patients having more than a 50% reduction in skin lesions. This agent has moderate toxicity, which I'm not going to go into for the sake of time. And then pralatrexate is also approved for relapsed and refractory peripheral T-cell lymphoma. In the PROPEL study, there were 111 heavily pretreated patients who achieved a 15-month overall survival, 4-month progression-free survival, and about a 29% overall response rate. And as we know, with dihydrofolate reductase inhibitors, cytopenias and mucositis are a concern there. Then in terms of histone deacetylase inhibitors, romidepsin and vorinostat, these agents also have activity against cutaneous T-cell lymphoma, generally used in progressive disease after previous therapies. And these agents are suitable for patients with skin involvement, actually with a variety of clinical presentations, either just skin involvement or with erythroderma and with lymphadenopathy or blood involvement. So the outcomes here, romidepsin, about 35% overall responses and very small amounts of CR, only around 5%, but these were small studies. And vorinostat had a comparable overall response rate, but specifically vorinostat has been shown to relieve pruritus, which is important in the management of these patients. This is just a nice table. I don't actually think there's much time to go into this, but it's just kind of showing. This is from a group at the Memorial Sloan Kettering Cancer Center in the US. That basically just compared these advances in systemic therapies for mycosis fungoides and Sézary. So I'm going to talk about the targeted immunotherapies quickly, but just we mentioned, or Stephanie also mentioned, these kind of interesting targets, the KIR3 DL2 target, where we can use, or one can potentially use this antibody like lacutamab. I have no idea what this antibody is, but it targets this natural killer cell receptor. And then this interesting E7777 agent, which is recombinant IL-2 and diphtheria toxin protein. This agent was taken off the market because of concerns about manufacturing and capillary leak syndrome, but apparently there's a newer agent that's being repackaged and retested, so this may still become relevant. Let's quickly go on to the targeted immunotherapy. So mogamulizumab is an IgG1 monoclonal antibody that's directed against chemokine receptor 4. This chemokine is involved in the trafficking of lymphocytes to the skin, and this has been approved in patients with at least one prior systemic therapy. The Maverick trial was a large open label randomized controlled phase 3 trial where 372 patients were randomly assigned to receive mogamulizumab or vorinostat. And actually, mogamulizumab significantly prolonged median progression-free survival compared to vorinostat. So it's certainly an option if it's available. I must mention brentuximab vedotin because this is really important. So in the Alcanza trial, this agent was looked at in 97 patients with CD30 positive MF and across all stages. So it was a investigator's choice versus investigational agent. There was a choice to either use BV or physician's choice. So very significant difference in overall responses between brentuximab and physician's choice. And then just a quick word on the CD30 positivity. So arbitrarily in this trial, they assigned CD30 positivity as more than 10% CD30 expression in skin biopsy, but this appears to be not necessarily a good assignment, because the patients express CD30 variably in different tissues, and even in the same patient, and from biopsy to biopsy, this can vary. So the suggestion is that one should obtain multiple biopsies, because if CD30 expression is not very high, it may these patients may not be assigned to this drug, and there may still be therapeutic benefit from giving BV. Then Pembro and alemtuzumab also have been looked at in this disease. Pembrolizumab, as we know, is a PD-L1 inhibitor, checkpoint inhibitor, and this has a limited role in refractory MF. Alemtuzumab, we're all very familiar with as well. This seems to have a place in relapsed refractory mycosis fungoides, as well as Sézary with erythroderma. And alemtuzumab has a significant improvement in erythroderma in these patients, with about a 55% overall response rate, and reduces severe pruritus. Extracorporeal photopheresis is a modality employed primarily for skin and blood involvement. It basically treats blood extracorporeally with 8-methoxysorolin and PUVA, and this is well tolerated but only available at specialized centers. Transplant is the only curative therapy, as we've said, reserved for clinically aggressive disease and multiply relapsed disease. And it's interesting that the best timing for this for allo would be at the time of best response to therapy, rather than waiting for a patient to use up all their treatment options and be multiply relapsed and refractory. Then this would not be a good time to pursue allo. Supportive care is incredibly important. I'm going to try and end with this. So it's really important to manage pruritus and infections. So co-management with a dermatologist with expertise in cutaneous T-cell lymphoma is important. Patients need to use things like unscented soaps and emollients and topical steroids, etc. And then systemic agents to reduce pruritus are listed. In terms of infections, one must optimize skin barrier protection, treat Staph aureus that Stephanie also mentioned. So this is an incredibly important supportive measure. So if patients are colonized with Staph aureus, one needs to culture that staph and determine sensitivity of the organism, so that the correct this would be if one is actually treating staph, one needs to actively address according to the culture of the organism, and use mupirocin nasal ointment to eliminate carriage. So just again, back to our patients. Mr. MG, his first line was methotrexate and topical therapy. Second line, unfortunately, this gentleman really has had a very recalcitrant course with multiple relapses. We've used single agent gemcitabine, which he responded to transiently, and then progressed again. We employed chlorambucil and prednisolone, which is kind of an option in resource limited settings. Also transient response, and now we are trying oral etoposide. And then the other patients mentioned earlier essentially are quite early in their treatment course, and they so far have only started oral methotrexate and topical methods that Dr. Kalawan mentioned. So just in my conclusion, we've said that the diagnosis and management of this disease is truly multidisciplinary. Generally, therapies that can be tolerated for longer durations with lower rates of toxicity, less immunosuppression, and high efficacy are used before moving on to options with a higher cumulative toxicity and immunosuppression risk. These agents are given in an ongoing or maintenance fashion. Systemic therapy is combined with skin-directed therapy, and then the agents that we've spoken about briefly are approved by the US FDA, and then other therapies also offer benefit but have only been evaluated in small studies. Treatment is individualized, and the supportive care measures are really critical. So so I've now sort of rushed through this last part just to make up time and allow maybe a few minutes for comments or questions. But thank you very much for your attention, and I'll hand over to Jacques if there are any questions or comments.
Thank you, Stephanie, Yashika, and Caroline. I think that was really a tour de force really very nice deep dive. And I think it's important that we have this because, at least for myself, because this is we don't treat Sézary syndrome or advanced mycosis fungoides commonly. It's often and because of the complexities of diagnosis and treatment and workup, it's often a bit of a panic the first time you get the referral of the patient. So it's really good to have this overview. And I think one of the important aspects that I've learned and in the few patients I've treated is this concept of limiting the toxicity single agent and going from one agent to the other, unless you can get the patient to transplant where you need to go more aggressive, get them in a remission, try and transplant them. But my understanding from speaking to the state transplant colleagues is that it's not done very often because patients are often not, you don't get them in a good remission. So I would appreciate any comments if anybody has transplanted a Sézary successfully. And then just maybe one thing to note that in terms of the diagnostic workup, the importance of doing lymph node biopsies if they are present, preferably guided by PET-CT. But if you don't have that, the sort of sequence is cervical, axillary, followed by inguinal in terms of your order of biopsy, because not all clinically palpable lymph nodes are actually involved. They may just be dermatopathic lymph nodes. And it's important to determine for the staging, because the staging directly affects your treatment options, skin only versus systemic, and so forth. Obviously, a Sézary syndrome will need systemic therapy, but in the mycosis fungoides earlier stages, it may have significant impacts. Any comments or questions from the floor? There wasn't. I asked a question in the chat box, but I didn't get a response. So I see.
Jock, sorry, I think we've lost you there. Your connection is a bit unstable, I think.
Yeah, I
Okay,
have had problems. I was actually thrown off the talk for a while. So yeah, then that just leaves me to thank our three wonderful speakers. I really enjoyed that talk and actually learned a lot. And I think the main take-home message is that you need a good pathologist, you need a good clinician, a good dermatologist to manage these very tricky patients. So thanks for that. It was brilliant.
thanks so much.
Excellent. Good afternoon for everybody.
Bye-bye. Have a nice afternoon.